So last day, we just got started on respiratory infections, and we were talking a little bit about strep throat. That's caused by Streptococcus pyogenes, which is pretty typical kind of opportunistic infection. It seems to appear to be able to infect a lot of body systems, also known as group A strep, but most famous for strep throat. We also talked about pneumonia, and pneumonia is often caused maybe 60% by another streptococcus, so Streptococcus pneumonia. And you know, that's a bacterial infection, but there are many other causes of pneumonia, of course. There's other bacteria that can cause pneumonia, and there's also viral causes. So I think I mentioned last day, one of the big differences is obviously treatment, because bacterial pneumonia we can treat with antibiotics, and viral pneumonia, mostly we're looking at treating the symptoms. I'm not going to talk about diagnosis between viral and bacterial pneumonia. I don't feel qualified to do so, and from what I can find, there's some conflicting information out there, so talk to a physician. My understanding, though, is you're more likely to have a fever with bacterial pneumonia than viral pneumonia, but I'm not 100% sure about that. Okay, so lots of people showing up late here. So please try to start your Zoom meeting on time, please. Okay, so today I want to talk about tuberculosis. I know we've been talking about tuberculosis kind of on and off, that it has some unique biology. So if you remember, tuberculosis has that special cell wall, and that special cell wall has that mycolic acid. And so it falls under a group of bacteria called the Mycobacterium. And it doesn't stain typically under a gram stain. And so we have an acid-fast stain for that. So some people are having some issues with the connection, it sounds like. So sorry about that. I don't know where the issue is. I guess we're just all doing our best here this year. So no worries, just a reminder to connect on time if you're able to. So you can see this note I have here, right, about tuberculosis. It may kill more people than any other infectious disease. We're not exactly sure of the numbers. You know, and every time I look up the numbers, I'm seeing huge differences between different studies and how many people have it and how many people are dying of it. And partly because this is a disease in the developing world where it's predominant, and a lot of those people are just dying and nobody is necessarily diagnosing it. But that being said, there may be 1 billion people worldwide infected. We're not sure. Could be 500 million, could be more, but some of the higher estimates say there might be 1 billion people infected, but they don't have symptoms. Not everyone necessarily has symptoms, but they may develop them later if they become immunocompromised. So tuberculosis used to be very serious, right? Because it used to be everywhere. And thanks to modern medicine and sanitation, it's been kind of disappearing from the developed world, so places like Canada. If you ever watch old movies, or movies that are, you know, have historical aspects of them, sometimes they talk about consumption. So consumption means tuberculosis, because usually people are wasting away, they're not eating, and so they're losing weight. So there are 2 areas in Canada where tuberculosis is a big deal. One is in Canada's north, and I can't remember the exact stat. I think it's 6 times more common in Nunavut than other places in Canada. I could be wrong with that number, but it's quite a bit higher. And there's a number of issues, right, with Nunavut is you're looking at a lot of really remote, very small communities. There's communities up there of 100, 200. There's healthcare, right? There's not a lot of these very small communities don't have hospitals and may not even have doctors that are there regularly. And tuberculosis is not something that a lot of doctors actually have a lot of practice in diagnosing, right? So, you have a cough, it could be a whole bunch of other things. A lot of people, when they have a cough, they're not necessarily reporting it or going in. And that's something, right? A persistent cough is kind of one of the big symptoms of tuberculosis. And so this is a few years ago now, and they're just talking about, trying to promote education around tuberculosis in Nunavut to, and have people who are visiting physicians and nurses a little bit more aware that it is an issue and that it does pop up once in a while. I mentioned there are two areas in Canada where tuberculosis is a bigger deal. The other area is actually street people. So people are homeless or living on the street. It's a little bit more common. And we do have a tuberculosis unit in the hospital. I don't know what the number of cases look like and all that, but it's enough of an issue that we do have a tuberculosis unit. So people that are specializing in the treatment and presumably diagnosis and care of patients with tuberculosis. So let's talk a little bit about the disease of tuberculosis. Here's some nice pictures I found, and you can see what is happening is that, so I mentioned that the disease is, one of the main symptoms is coughing. And so it's spread by usually respiratory droplets, but it can be aerosol. And it's somebody's asking if it's super contagious. My understanding is it's not super contagious. So if you're exposed to someone with tuberculosis once or twice or even a few times, it's probably not a big deal, is my understanding. My understanding is most people who get tuberculosis, they're getting it from someone they have repeated long-term contact with. So a family member or whatever. There's probably, as I mentioned, something to do with sanitary conditions and whatnot in terms of ventilation in homes. I'm not entirely sure. I think there's actually a little bit of a mystery as to why tuberculosis disappeared so dramatically in the developed world. I don't think there's necessarily a consensus on that. But basically, it's spread by respiratory droplets most of the time. And these bacteria are relatively stable. They have those mycolic acids, and they end up in someone else's lungs. And in the lungs, we have immune cells, these macrophages that scoop things up and try to kill any invaders. But these have that mycolic acid. And so these can actually survive phagocytosis, and they can live in those immune cells. And they can live in the lungs, where those immune cells are basically swimming around. So you can see here that they might multiply a little bit. They're very, very slow to multiply. If you study tuberculosis, most bacterial cultures, you can grow up a culture overnight and study it the next day. This we're talking about, I believe it's weeks, like 8 weeks or something like that, to get a decent culture. So it's very, very slow to grow. So the disease is very, very slow to propagate. But anyway, you can see we've got more macrophages. They're swallowing it up, and they're not, they can't kill it. And they sort of congregate, and they form these lumps that are visible on an X-ray called tubercles, I guess is how you say it. And eventually, sometimes these cells do start getting released, which you can kind of see down here. And this is where it might actually start getting infectious when it gets to a certain point where there's a little bit of tissue damage and the person is developing a cough. But at the early stages, often it's latent, which means it's not infectious, and it's just kind of very, very slowly growing, and the person usually doesn't even have any symptoms. So you can see here, it's bursting, it's getting into the alveoli of the lung, the person probably has a cough, and now suddenly they're infectious. And it's symptomatic enough that these tubercles are visible in an X-ray. So there's kind of a cartoon. I think I've got an X-ray on a further slide, and like I said, they're just big enough to be visible on an X-ray, and apparently it doesn't quite look exactly like pneumonia. So let's talk a little bit about tuberculosis progression here, right? So you can get exposed to it, and you can see that exposure, a small percentage of cases, and like I said, my understanding is that it's usually prolonged repeated exposure is what gets people infected. So most of the time people aren't getting infected. Sometimes they do. Like I said, depends on the bacterial load and the prolonged kind of continued exposure, and then someone might eventually get infected. So and then what happens next, right? You get infected by the microorganism, and in about 10% of cases, people develop active disease within about a couple of years. Some people, it takes a little bit longer. Apparently 90% do not get active disease. So was trying really hard to confirm these numbers, and I had a really hard time finding data on this. So maybe in the future I'll confirm these. I'm just not entirely sure, because I know I read somewhere else that people who have latent tuberculosis, the number that develop active disease is probably much higher, but I'm not entirely sure. So basically what it means is there's a lot of people out there that got latent tuberculosis, and they don't have symptoms and they're not infectious. And there's a number of people that do. And usually, if you have latent TB and you get some sort of immunosuppression, so I mentioned before, I think in Africa, if you have tuberculosis, pretty much the very next test is test the person for HIV, because they're suspecting some sort of immunosuppression, and that's why they've developed, the person has developed tuberculosis. So, in terms of where we're at, apparently it's pretty high. So about half of the people will die from it if it's untreated, and some people remain sick for a long time, and some people recover. I'm not sure why those numbers don't add up to 100%, right? But that seems to be the way these things are sometimes. If you're looking for a really good web series, maybe I'll post it on the Facebook page. There was a guy, he was some sort of YouTube type rapper kind of guy, and he ended up with tuberculosis, and he has all these videos about it where he raps about it and talks about it, because he was stuck in quarantine in a hospital, and of course it turned out to be multi-drug resistant, so he was stuck there for like 6 months and had nothing better to do, and it's actually a pretty good web series on it. So I'll see if I can post that for you if I remember to do that on Facebook. Very fascinating. So detection, we talked about tuberculosis detection in a few cases. There's the chest X-ray. So the classic detection, kind of depending on where somebody is coming from, if there's suspected tuberculosis, the classic thing would be to do the acid-fast stain. Usually the X-ray is first, and they look for the little lumps. And then maybe if someone has a sputum sample, it would get acid-fast stained and sent to a technician. The immunofluorescent stains are a little bit more common now. They're a little bit easier to do. They're quicker, they're more reliable, and they're getting to be a bit more common. There is a PCR test for tuberculosis. My understanding is it's not used so much anymore, and there's an ELISA test. And I'll talk about those trained animals a minute and a skin test in a moment. There is a newer test, and I can't remember what it's called, and it's been out for at least 5 years. And oh boy, I just can't remember what it is. It's a blood test, and it's looking for a certain immune molecule that gets triggered when somebody has tuberculosis. And apparently it's highly accurate and highly sensitive. I just didn't have time to kind of read up on it and feel confident enough to talk about it for this class. But like I said, there's a number of techniques that are used. The ELISA test, like I said, that the one that I was reading about apparently isn't very reliable. So let's talk about the skin test here in a moment. And I just want to mention trained animals. Apparently, you can train animals to smell it on people. And dogs and pigs have been used. And this is not used in Canada, but I was reading a really fascinating National Geographic article about this. Apparently, there are places in Africa where they train rats to do this. And I don't know how this works. I have no idea, but apparently it's relatively sensitive. And the rats, well, they're cheap. And, so why not, right? Like, these other tests, right? To do an acid-fast stain or a PCR, you need qualified, trained technicians. This is not cheap. and the tests themselves are not cheap. Rats are cheap, apparently, once you've got them trained. So, you know, you can look that up. Like I said, I think it was National Geographic. You can look up trained rats and detection of tuberculosis. It was really interesting, and that was a few years ago I read that article. So let's talk about the skin test for a minute. So my understanding is, and you can correct me if I'm wrong, that part of the nursing program, you do have to get the skin test. I know that used to be the case. I don't know if they're still doing it. I know there's a lot of occupations that's kind of a standard thing to do. It's not always going to work. It's not 100% effective, but it's kind of a quick way to test someone for tuberculosis to see if they have it or if they have latent tuberculosis. Like I said, it's not always going to work, but it's a pretty easy test to do. And if you've had the test, you probably know that it's kind of something that you know, they basically prick or scratch your skin, and then they check you. I'm not sure if it's 24 or 48 hours later, so it's kind of a delayed immune response. You know, every couple of years, some student will actually come forward and tell me about their experience, because there's always somebody who tests positive for various reasons. I'll tell you two stories about, actually three stories about this. This happened to my mom. She, when she retired, she became one of those school crossing guards, you know, in her retirement. And, you know, so she was doing that kind of every morning. But to work for school board, she had to get the skin test. So she went in and got the skin test, and she came up positive. And then at that time, the next step was the x-ray. They didn't have the blood test. She didn't have symptoms, and her x-ray was fine. And what they figured with her is that she was old enough to have actually been vaccinated against tuberculosis. So this is the case where I've had students that were born and maybe partially raised in some countries. So I think I had a student from India that this was the case. I think someone from, was it Portugal? In some places in the world, they're still giving the vaccine. And so if you've had the vaccine, you are going to have an immune response against this. And then my last story is that I've also had one or two students that have actually tested positive, and they found out they had latent tuberculosis and had to get treatment for it. So this does happen once in a while. You know, like I said, it used to be relatively routine. Now the odds of having tuberculosis, at least if you're, for most people, is relatively low. So let's just talk a little bit about comparing latent tuberculosis and active. As I mentioned, with latent tuberculosis, there's no symptoms. I don't feel sick. The organism is multiplying at a very, very slow rate, or sometimes even kept in check. If you have active tuberculosis, the big thing is the cough, right? These persistent cough that's lasting for weeks. And with cough comes all the other kind of related symptoms, so pain and sometimes you know, mucus and blood being coughed up. I mentioned weight loss, and probably, you know, most people know when you're feeling sick, you're just not feeling hungry, and that's kind of a big part of it. Sometimes fever and chills and weakness and things like that kind of come along with most illnesses. I also mentioned that latent tuberculosis, as far as we know, it's not spread because, well, the person's not coughing, and that's the method of transmission. Whereas with active tuberculosis, it's mostly respiratory droplets, but there is some evidence that it's aerosol spread. And I think I mentioned this a couple of weeks ago. I was reading about a study of somebody who proved that tuberculosis can be spread aerosolly by, they had guinea pigs, and they made special cages that were kind of up in the ventilation in another room or something like that. And they were showing it was able to spread from one room to the other to the detriment of the guinea pigs. So it sounded like a complicated experiment, but you know, some probably necessary information as to why some people get it and they don't know where it came from, and that does happen. So diagnosis, so latent tuberculosis, the skin test is kind of the big one, right? No, it doesn't work. Apparently, it's 80% effective anyway. Often if people have a positive skin test, they might get one of these other tests. So like I said, traditionally it was the x-ray, but now we have this thing here So I guess it's some sort of type of ELISA I have written down. Like I said, I haven't had a chance to really read up on it. It's been out for a few years. All I know is that it's apparently highly effective at diagnosing it. And this is part of the diagnosis now. And, you know, this is the way things work, right? You know, new technologies change things all the time. Sometimes it's cost, sometimes it's sensitivity, sometimes it's just where you live. You know, something that might be standard in Alberta may not be standard in Newfoundland or Ontario or something like that. If you have active tuberculosis, usually the skin test is going to come positive. Usually there's symptoms, so you're going to have an abnormal X-ray and all those kind of things, right? So treatment, this is where it gets super complicated, and this is something that changes all the time for tuberculosis because there is multi-drug resistant tuberculosis out there. So if you have tuberculosis and you're from certain regions on the globe, that may actually affect your treatment regime. For example, if you're from Madagascar, I'm not exactly sure why Madagascar has a really high rate of multi-drug resistant tuberculosis. So if you're from there or anywhere near there, they're going to treat it much more seriously, and they're trying to throw a whole bunch of different drugs at it. These regimes will often last 6 to 8 months, and you're looking at, you know, month number 1, maybe 6 weeks you're on this drug, and then you're 6 weeks on this drug. And like I said, these therapies kind of change all the time in terms of the best information and you know what kind of tuberculosis they think you have. Traditionally, though, if you don't have, if they don't suspect you have multi-drug resistant tuberculosis, it'll be a single drug, and the isoniazid, which is the drug that we talked about back in topic 10 or whatever the topic that was. So that's kind of it for tuberculosis. Like I said, I wanted to just kind of give you a little bit more detail about it. Most of these things are things we sort of touched on a little bit, but sort of see it all there in one package. And so there is a chance you will see it in your careers. And we'll see. There's a lot of people, a lot of researchers out there that are terrified of the multi-drug resistant tuberculosis because it does seem to be making a bit of a comeback in some areas of the globe. So what about viral respiratory infections? There's a whole bunch of them out there. Some of them are causing pneumonia, and some of them are causing other infections in infants and whatnot. And I kind of wanted to focus on these 3 here, of which we've kind of mostly we've talked about all 3 into some degree. I'm also going to throw norovirus in there because sometimes people mistakenly call it the flu, and sometimes it's often called the stomach flu. So I'm going to come back to norovirus later, but I'm just going to throw it in this chart here to compare and show you that it's not the flu, right? The flu is a short form for influenza, right? So, you know, we don't want to confuse that. But like I said, I threw it down here, and you see it often with during flu season. Alberta Health is often trying to make that distinction too, because people you know, have norovirus and they think it has something to do with the flu shot and things like that. So all of these are different viruses. The common cold, mentioned a bunch of times. One of the main viruses are rhinoviruses. Rhino means nose. But there's coronaviruses. There's 4 cold coronaviruses that infect people. There's adenoviruses. There's parainfluenza. There's a whole bunch of them out there, more than 200. And COVID-19, so that is a coronavirus disease 2019, because that's when it was first noticed, is caused by the SARS coronavirus 2. And influenza is caused by influenza viruses. There's actually 3, A, B, and C, that can infect humans. Usually influenza A is the main one that's causing human disease. And then, of course, the stomach flu, which I'm going to try to avoid calling it that, is caused by norovirus. So they're all different viruses. Interestingly, they're all RNA viruses. Some are enveloped, some are not. But that's kind of interesting that they're all RNA viruses. So the kind of one of the main things, this is a good takeaway message, is that which ones of these are treatable, or at least preventable by vaccine. So at the moment, influenza is the only thing that we have approved vaccine for. And it's a yearly vaccine because of the mutations that happen in this particular virus. And unfortunately, it's not the most effective vaccine, 40 to 60%. Compare that to the measles vaccine, which is like 97% effective. Not saying don't get your flu vaccine, but you know, unfortunately, we have to get it every year or two, and you know, people just don't like getting jabs, right? So hopefully, if we're lucky, when I give this lecture next year, I'll be able to add that we have vaccines for COVID-19, but at the moment we don't. We just have many in the pipeline. So let me just talk a little bit about symptoms of these things, right? So if you look at the flu, right? Main symptoms here, right? Fever, headache, and aches, right? Those are kind of the main symptoms of the flu, sometimes a cough. If you look at the cold, a common cold, sometimes we call it the head cold, right? Because it's mostly head symptoms. So stuffed sinuses and then runny nose and sneeze and those kind of things. So not usually necessarily you're getting a fever. Some people, it's more common to have headaches and those kind of things. COVID-19, one of the main symptoms is, of course, a fever or chills. And when I had COVID-19 and my family members, we all had headaches. Apparently, some people that's a common symptom, but not everybody. Aches and pains, sometimes, but the flu, usually almost always a fever and aches and pains. Looking at other symptoms, right? Common between COVID-19 and influenza is a cough, whereas a little less common with the cold, right? So something else to think about. And of course, COVID-19, the one that everyone's worried about is getting this one here, which is shortness of breath. Whereas a common cold, like I said, the symptoms are higher up in your respiratory system. So you're looking at, you know, sore throat, sinus issues, snuffles and sneezes and things like that. Loss of appetite. So this is not none of these are really gastrointestinal diseases. Apparently, it's a little bit more common with COVID-19 for people to have a little bit of diarrhea. You know, it's surprising that this respiratory virus actually infects a number of body systems, which is kind of one of those surprises that has come along with this new pandemic. With influenza, sometimes people have diarrhea. It's more likely in children. But it's kind of, you know, one of the main symptoms, right? I mean, if you take a look at norovirus, it's the exact opposite. Most of the symptoms are over here in this area here, right? So diarrhea and vomiting kind of being the big things. So like I said, we'll come back to norovirus in a few minutes when we talk about digestive diseases, right? Possible complications, all of these things can lead to secondary infections. And that's kind of one of the big things that with COVID-19, that some people are having secondary bacterial infections, secondary pneumonias, those kind of things. Same thing with influenza. You know, people will die of influenza. And then actually, in many cases, they're dying because of secondary pneumonias they're getting after having influenza. And, you know, with COVID-19, we're still learning about all the complications. You know, some people are getting blood clots, and some people are ending up with something called, you know, foggy brain, you know, and cognitive things. And I mean, it's just, I mean, this is one thing that has just been surprising about this current pandemic, is this disease just has so many weird things it's throwing at us. And you know, probably because it does seem to be infecting the vascular system of some people, which of course is found all over the body. A couple people making comments, somebody making a joke about people buying toilet paper if they're not having all this diarrhea. Yeah, I think with toilet paper buying, people they don't like pandemics. They don't like having no control over their life. One thing they can control is how much toilet paper they buy. So that's one way I look at it. Some people's asking about, do we need to know this chart for the file? Just kind of in a general sense. You know, we know these are all respiratory diseases, and you know, I think it's important to make some distinctions just for people to know. And I think I think, like I said, there's a lot of complicated things here, and so you know, just know the basics on this chart. Yeah, someone's talking about norovirus. We'll talk about norovirus in a few minutes. So let's talk about COVID-19, that short form for coronavirus disease 2019. So the virus was only discovered in January itself, but there were people with kind of a unique sort of pneumonia. It was described as earlier than January, so 2019. And so the World Health Organization, I think, named it, and we all call it COVID-19. Maybe in the future it'll just be COVID, because it'll probably be around with us forever now, unfortunately. So the cause is SARS-CoV-2, which is a short form for severe acute respiratory syndrome coronavirus 2. So we talked about the animal origins of this virus. I think, I can't remember what it's called, the something nose bat, some bat that's been found. And of course, you know, people are talking about the origins of this being China. But, you know, bats are not just found in China. Bats migrate like birds. They're actually found all over Asia and Europe, these particular bats. So we don't really know where it originated, but the initial diseases certainly were discovered in China. And then, of course, you know, the rest is history. And we're all living some history right now. Not the history we wanted to live in, but I guess that's life. So it's highly contagious. I mentioned it's respiratory, but also known to infect the vascular system, and the symptoms range all over the place. So there's a little image of the virus, and these little spike proteins here. Little spike proteins are what many people are trying to make vaccines against, because we believe that's what the immune system will be able to recognize. So symptoms, like I said, huge variety of symptoms. You know, kind of the main ones are fever, sometimes difficulty breathing or shortness of breath in severe cases. And a big one that seems to be popping up is this loss of sense of taste or smell. And apparently about a third of people are experiencing that. And that actually happened to me. I had no respiratory symptoms when I got sick. But I, you know, had some chills, and when you're chilly and sick, you make yourself a tea. And I have this tea in my cupboard that just tastes awful, but I'll drink it when I'm sick, because I figure when I'm sick, you know, there's a psychology thing around when I'm sick. I feel like that medicine should taste bad, so bad tasting tea, it's, I don't know, some sort of weird logic. Anyway, I make the tea and it tasted like water. And I'm like, wow, this is weird. I've lost my sense of taste. I came back after a week. But I know somebody else who had COVID-19 back around when I had it in September, and he still has no sense of taste or smell. So probably this has something to do with some kind of chronic inflammation in those tissues, because I've heard that you know, they're starting to learn how to treat this. They're giving people antihistamines and steroids to spray up the nose, and it actually can treat this. I don't think that's standard yet, but that seems to be the case. And of course, we're starting to talk about long COVID now, meaning people who suffer long-term symptoms of this. So basically different types of inflammations and different types of respiratory kind of long-term symptoms, probably due to damage that was caused during the viral stage. And we do know that the risk, of course, is much higher as you get older, and you know, so 60 and over seems to be where people are more likely to have severe disease, but it's not like it doesn't happen in younger people as well. So a couple of questions here. It says, do we know the life cycle of this virus? Yes. I don't think I actually have it in the slides here, but it's an RNA virus. And it replicates in the cytoplasm. And I think I'd mentioned that before, with this disease, there's usually people who have severe disease, it's usually 2 stages of symptoms. So they have some viremia, so that means that's when the virus is replicating. That's kind of within the first week. And that's where people will have kind of, you know, so the virus is replicating in the chest, so you might have respiratory symptoms, and then other sort of typical viral kind of symptoms where the immune system is reacting. So fever and aches and chills and things like that. And then people who have more severe disease often will have a second week of symptoms that are where the virus is gone, but they're still dealing with kind of those immune signals, so cytokine storms And this is where some people will end up on ventilators and more severe symptoms. And so we're starting to learn how to treat that. We give people steroids to sort of, deaden that immune response a little bit and minimize the symptoms. So somebody's asking if you've had COVID, are they immune? And we don't know. We're learning a little bit about this now. We're kind of just trying to get these studies, and we don't really quite fully understand how the immunity to this virus works. Presumably, there's some immunity, how long it lasts, and how good it's going to be. I think one of the big questions is, what if I'm immune, but I can still get infected and then spread it to somebody else, that kind of thing. But probably, I'm guessing, the viral loads, we can show that the viral loads do go down after 10 to 14 days. In like 99% of the people that we've studied. There's been 1 or 2 anomalies of people that seem to have the virus a little bit longer. And as far as I know, I've not been exposed to anybody else since. Like you folks, I've since September, I feel like all I've been doing is working. Just don't have the time to get out so much at the moment. Okay, so what else can we say about this? I think we mentioned before, transmission is mostly respiratory droplets, which is why we're trying to have that, social distancing. And I made these little graphics I was showing people earlier because people were like, 2 meters, what's that? And I'm like, you live in Canada, you probably learned the metric system at some point in your life. So how big is 2 meters? Roughly about 2 dogs. Or you can think of a larger mammal. Somebody was telling me a llama was that big, so I made that one. Or about the height of Batman, right? So thought you might enjoy those pictures. There is other transmission. We're not exactly sure what percentage. Maybe 10% of cases are from fomites and some aerosol transmission as well. Because there are some people that once in a while seem to get it and they have no idea where they caught it from. So probably from a fomite or aerosol transmission. But most of the cases we can trace back to, they were in contact with somebody or hanging out with somebody or birthday parties or, all sorts of things like that. So the incubation period apparently is 1 to 14 days. The average is about 2 to 3 days. People will incubate before they get symptoms. But it can range from 1 to 14 days. And that's why we have that 14-day quarantine thing going on. If you've been exposed, you're supposed to stay at home for 14 days just to make sure. Because we're trying to prevent the spread of this thing, right? I think there are some new recommendations that recently came through. Somebody's mentioning that to 10 days. Yeah, and I was going to say I haven't actually read, I saw it in the news, but haven't had a chance to actually look it up yet. There's new recommendations depending on when your test was and those kind of things. But somebody's saying they thought it was 10 days. But like I said, I'm not sure without looking that up. Because I'd heard about it, but I hadn't had a chance to kind of look into it. So treatment, we're kind of treating the symptoms, depending on where you are. It could be bad. You could be talking about ventilators. In most cases, it's kind of stay at home and let your body do the work. If your case is not severe, just simple things like Tylenol and rest and those kind of things, right? Someone else is saying she knew someone who got tested after being in contact and was positive, and the result came back negative. Then on day 11, he had symptoms, got tested and he came back positive. Yeah. So like I said, 1 to 14 days incubation period. For some reason, that's huge. And this is why this virus is so successful, right? This thing is infective and people don't have symptoms. Very easy to spread, and having this long incubation period, it makes it very, very difficult to manage. When we had SARS-1 that came by in 2003, it was the exact opposite. People were dying, it was very bad, but they were mostly only shedding virus when they're symptomatic. So it's very easy to see someone who has symptoms, okay, quarantine them now, right? And that was kind of dealing with the issue, and it was the epidemic, literally was only a couple of months in Canada for that. So at the moment, we're hoping for vaccines. I know it's been in the news all over the place and wondering when Canada is going to have them. One thing that came revealed recently, even though Canada has spent a lot of money, on these vaccines. We don't actually have production facilities for that kind of scale in Canada, so we may be a little bit slower to get the vaccine, unfortunately. We'll see how that all plays out. Somebody's asking what they're doing to mitigate blood clots. I don't actually know the answer to that. I know I was reading about it somewhere, and I'm not sure if there's actually a standard type of care on that. You know, with the longer term stuff, I think there's still a lot that we're learning. And I think sometimes the blood clots are a little bit of a surprise. So I don't know if they're doing anything preventative as well. That's a good question. Okay, so that's it for COVID-19 for now. Back to influenza. We've kind of talked about influenza a lot already. We have, of course, there's several influenza viruses out there, and some of them are found in animals, most notably birds and pigs. And you can see this little cartoon is showing, right, that type A can infect all three of us. Type B and C are found in humans, but type A is the one that usually causes the most severe disease, and is the one that we're usually the most concerned about. So remember, we have these proteins on the outside of the virus, H for hemagglutinin, and N for neuraminidase, and that's usually how we classify the viruses. So I think the human viruses are usually H1, H2, or H3, and I can't remember for N which ones we get. And the bird viruses are usually H5 to H9 and so on. Like I said, I can't remember all the details there. And here's some of them. And you know, we're at the point now where we're actually getting, before 2009, most of our seasonal strains were the H3 category, and I think now most of them are in the H1 category. But the flu shot, if you take a look at the package insert, this past year, I think it was actually 4 different strains they were giving people an injection for. And something else we talked about is that, and I kind of just mentioned that with COVID, is that with viruses, there's kind of 2 kind of categories of symptoms, right? Some of the symptoms are caused by the viral replication. So in the case of influenza, it's replicating, you know, down into the respiratory system. And those ciliated cells that you have down there, down your windpipe, are basically getting decimated. They're getting killed left, right, and center. And what does that lead to? It leads to cough. It leads to sometimes chest pain, depending how deep it gets in there, right? Most of the other symptoms are your body's response to viruses. So you have those interferons, and you have other things that are going on and recognizing that there's a viral infection. And so fever is very, very common with almost every viral infection that goes systemic, or chills, right? Sometimes headaches. Sometimes muscle aches, and those are all immune reactions to the flu. And so, you know, sometimes those are kind of the reactions we get to the flu shot as well. And so, you know, because those are just the immune system working. And so, you know, they're usually not as severe as you would have with the virus. Usually they're a lot more mild with the flu shot because of that, right? So I think my next slide actually talks about the flu shot. And so we have a new virus every year because of antigenic drift. And so that's just kind of a slow, gradual mutation. And so because of that, every year we formulate a different flu shot, which usually has, it used to be 2. And like I said, this year we're up to 4 different strains in there where we're trying to predict which strains are going to be the most common this winter. And that's what they put into the flu shot. Fortunately, it's a bit of a guessing game, and these vaccines take about 6 months to produce in the quantities that the Canadian government orders, and it takes 6 months to grow them up. So we have to do a bit of a guessing game by looking at patterns around the world and what's going on in the southern hemisphere. So the flu shot, the one that you get in the arm, is a killed, inactivated virus vaccine. And there's also the flu mist, which is a nasally given flu vaccine, which sometimes they give to children. It costs more, but if you have a child and you get the flu shot, you can request it. Although I think the last 2 years, they have not been having it. There was at least 1 or 2 studies showing that it wasn't as effective, and it's like way more expensive. And so I think they discontinued until they, at least temporarily, maybe they're going to look at some more research. I'm not fully sure why the discontinuation, and it could be available this year. I'm not entirely sure. We also mentioned there are some drugs that are used for flu. A little bit of debate and controversy of whether they're actually effective, because you've got this case kind of like COVID-19 where you have an acute illness, right, where it comes on and then it's going to, the virus is going to replicate, and if you want to prevent the virus from replicating, you almost need to take the drugs before you get infected, and that's when they're most effective, which is shown in animal studies. In severe cases, though, right, like we have this at least available to us, and kind of standard of care is we don't want to do any harm, and this might help. So like I said, the data is kind of questionable, but we are using it, and it's better than giving someone antibacterials, right? We don't want to be getting resistance for bacteria for no reason whatsoever. So sometimes that's why it's prescribed as well. I think I have these little slides here showing the antigenic drift, and so that's from slow mutations. And so people are asking me a lot about mutations and coronaviruses. So coronaviruses have an RNA polymerase, just like influenza, but they also have a proofreading function. So that means coronaviruses are way more stable, and I think it's something like 10 times stable than the flu virus. So it might mean that in the future we might get an annual coronavirus shot, or maybe it'll be every 5 years or something like that. We don't know yet, right? It's going to take us 5 years to get the data to really understand how our immune system is going to react to these vaccines and all those kind of things. So it'll be lots of research and lots of time it's going to take for us to really know these things. So the other thing that we talked about was antigenic shift, and looks like I have a typo on that slide. But what is that? That is where we have the infection of multiple viruses in one cell. So this is really rare and usually happens in a pig, because pigs have more receptors, right? They can actually get infected with human strains. They can get infected with bird strains. And so this is a very rare event. You have two viruses infect one cell, and if you take a look, influenza virus has actually multiple strands of RNA. So you get a little bit of mixing and matching occurring, and so you got some strains from maybe, let's say, the human strain, maybe from a pig strain or a bird strain. And now what we have is a virus that is unique and brand new and unlike anything the human immune system has ever seen before. And this is what happened in 2009. This is what happened way back in the day of the Spanish flu. And sometimes these are highly pathogenic and really nasty, like what happened with the Spanish flu. In 2009, it wasn't nearly as nasty. Some people did get seriously ill, and but most people were okay. I do remember, though, a lot of people did react from the flu shot this year. Like I said, it was that year. It was something new. I remember getting the flu shot myself, and usually I get the flu shot and there's like nothing. And in 2009, when I got that flu shot, I got home and I had a headache and I had some chills and I had a hot bath and I went to bed. That's what I remember about that. So, of course, we're concerned about this happening again. This is kind of showing the what happened in 2009 with the H1N1 that came up. And so this was an antigenic shift. And it was actually a mixture of 4 strains. 2 were swine strains, 1 avian bird strain, and 1 human strain to make this fancy new virus. And so this is what happened. The events probably happened before 2009, maybe a year or two before, but by the time it gets detected in humans, this is what we saw. The other thing that with these new viruses, they don't always behave like flu viruses, right? This one was surprising in that it spread really well in warmer places like Mexico, and young people were getting quite sick from this. So it was new and scary, right? And thankfully that's in our past. In fact, very few people are talking about it anymore until now, until suddenly we have another pandemic and people remember that pandemics are a thing. One of my pet peeves, by the way, is how quickly people forget things like that, when they're gone. So people, of course, are concerned about all these bird strains that we're monitoring. This is one that's mentioned in the textbook, H5N1, and of course we're worried that it could have some mixing in pigs and end up in humans. So we're doing all sorts of flu monitoring out there. So I'm not going to say too much more about influenza, except for that we have not seen the end of influenza. It has animal reservoirs in pigs and birds, and this picture here, you can see this is a farm somewhere in Asia, and it's very common for pigs and birds to be on the same farm. Of course, there's wild birds, and we're not going to get rid of this unless we go out there and kill every pig and bird on the planet, and I don't think that's going to happen. But it's not that we should kill every bird and pig on the planet. There are different types of, if you look at pig farming nowadays, we're starting to learn how to be a lot more hygienic about it. A lot of pig farms in Canada and the US and a lot of wealthy countries, the practices have changed hugely, right? In terms of monitoring humans for flu, because we can actually make our animals sick too, right? And it's actually pretty fascinating. I wish I knew a lot more about farming, but every time I learn a little bit, I'm really fascinated, because it's not like you're out there tilling a garden like some of us do as a hobby. Farming is a very sophisticated, technologically advanced practice nowadays, particularly at the scale that humans do it nowadays. Okay, so a couple other respiratory infections to talk about. We talked about there are some fungi that can give respiratory infections. A lot of them are more associated with people who are living in really bad conditions, or they're immunocompromised. So this one on the bottom here, histoplasma, is found in bird droppings, right, like pigeons or whatever, and it can be quite detrimental if somebody is immunocompromised or have AIDS. The big one that pops up is this one here, blastomyces, and it's found in soil and wood. And from what I can tell, it's actually not that common out west. Just geographically, it just must not be found in the soil out here as much, which is a good thing. And this one was something I talked about as a dimorphic fungi. So something at one temperature, so lower temperatures, it's mold-like, so it's fuzzy. And then at higher body temperatures, it grows more like a yeast. And so you can see that in those photos there. Here's the diagram. Yeah, so I had mentioned, that geographically it seems to be a little bit more east. So I don't know exactly where Fort McMurray is. So we're probably just up there somewhere. So a little bit out of the range according to this particular map, which is from Wikipedia, which, I'm assuming it's okay, but may not be 100% accurate. There's also parasites that infect the lungs. If you remember, I was talking about these life cycles and how these parasites will infect the body. And one thing they do is, the larvae, they ultimately want to get to the digestive system. So how do you do that? So the easiest way to do it is just, follow the blood, right? And you follow it all the way to the lungs, and then you go and you get to the back of someone's throat, and then you get to the digestive system. And so literally that's part of the life cycle of a lot of these worms. Hookworm, Ascaris, they migrate to the lungs and they go down the back of the throat. It's absolutely disgusting. But, if you can imagine what's going to happen there, this can lead to pneumonia. There's our hookworm. Like I said, that image there it was very terrifying. Okay, so that's it for respiratory infections for the most part. I did want to just take a quick break. So, stretch, and there's been quite a number of questions about the exam. So I did want to just talk about it for 5 minutes right now, and so that you have an idea of what you're up against. We'll do full-on review next week. We'll probably still have a little bit of lecture left for topic 14 into Tuesday. So Tuesday will probably be half lecture, half review, and then Thursday will be full-on review. Calvin Hobbes cartoon for you. I love Calvin Hobbes. They're just wonderful. I may have changed one word in this cartoon here. You can see he's trying to study and saying, abracadabra, command my studying to be done, and it didn't work. Poor kid. Feel sorry for him, but you know, he's cute. So what are we looking at? The exam is scheduled for December 10th. So a little bit of time for you there. I know you have other exams to study for, but the good news is we're not right up front. Don't know whether that's good news or bad news. Sometimes I find if I'm late on in the exam period, people spend all their time studying for all the other courses. So hopefully that doesn't happen to you. Hopefully you find a good balance. Much of the final exam is going to focus on the last topics, 11 to 14. That being said, you know, we're kind of talking about some of the same things. You know, we're talking about Staphylococcus, we're talking about E. coli, we're talking about tuberculosis. These things come up again and again and again and again. You know, so those organisms that have sort of, you know, transcended all the topics are those ones you want to focus on the most, because they're pretty much guaranteed to be on the final exam. So usually when I put this thing together, this is what I did last year. So usually I don't deviate from the plan too much. Excuse me. You know, I might tweak things just a little bit. You know, maybe I can't come up with enough fill in the blanks questions, so maybe I make it out of 15 and put the other 5 marks somewhere else, kind of thing. But usually I don't deviate from this plan too much. So very similar to the midterms, right? You know, you're looking at a combination of multiple choice, true, false, and matching kind of questions. Some sort of shorter answer, fill in the blank style questions, and then I guess for a short answer here, I should say case studies, right, is more what I'm looking at in that regard, where you have a question worth 5 marks that's around a theme. Let's say it's around E. coli or something like that. So when I make this exam, we've got 14 topics, and so usually what I do is I just go through every topic and I take, you know, 2 or 3 multiple choice questions, right? So the multiple choice kind of area is going to cover the whole course. I do, for the earlier units, try to avoid the super specific, crazy, nasty questions. You know, so I'm not going to ask you, you know, for example, I think I had on one of the sample questions for the first midterm about what genome the papillomavirus had, right? So, you know, I'm trying to avoid those kind of questions and be a little bit more general. And if there's something I said in passing very shortly way back in topic 2, I'm usually avoiding those things. I'm usually looking for the things that are following the themes we've been talking about a lot. So maybe, you know, I'll go back to let's say we go back to the unit on drugs, right? And, you know, penicillin, that was important. We talked about it a ton, right? So, you know, expect on the final exam some question about penicillin, for sure. What about all the other antibacterials? Maybe, you know, that's kind of, you know, getting to the really specific range, but if I feel there's something important in there, then I'll definitely ask you a question on that. So anyway, like I said, we're going to review next week, so hopefully you have lots of time to think about this. I think the biggest thing I can emphasize is that you should look at the study questions at the end of each unit, because that is where I look at when I write the exam. I look at those study questions and I try to build questions around those study questions, because I think those are kind of some of the big important concepts that you need to know for this course. So other than that, hopefully no surprises for that. Just quickly, I wanted to show you which topics we covered. So this is what we covered for midterm 1 and midterm 2. And so all the way up to antimicrobials. And then for the final exam, we're covering some heavy topics, right? This is why I kind of focus on this part, because I know this is heavy, although a number of these things are kind of going back and, you know, reviewing things we saw before, but from a different angle, right? So at this point, we've made it up to here, right? We made it up to there. So we still have to cover these other things here, but the other ones are just a little bit shorter. So we should easily be able to get through them. No problem whatsoever. And like I said, I'm hoping topic 14, enough of topic 14 is review, like at least like maybe maybe 2/3 of it is stuff we've seen before. And I'm just fleshing out a few things and kind of talking about things in a different theme, like around body systems, right? So I had this little cute thing I found on the internet. This is a joke, by the way. This is a joke. I'm gonna emphasize this. That I'm just kidding. You know, this is the way you hope it's not going to be, and I'm hoping for you there will be no surprises. You've had 2 tests with me now, and so you know hopefully what to expect and how to study. And like I said, I'm hoping there will be no surprises. There'll be nothing like this, and hopefully that you do see this as a joke. I do have some questions here. People asking if the final grades are similar to what we found in the midterm. Usually the trend I find is that the first midterm is the lowest, the second midterm is the highest, and the final exam falls somewhere in between. It depends on the group of students. In this case, the midterm averages were similar, I think within 1% of each other in this class, and that's more rare. Usually there's a much bigger difference between the first midterm and the second midterm in this class. So it's hard to tell. I would say most people are going to be relatively consistent. Some people are probably going to study their butts off and do better, and some people may do a little bit worse. So it's hard to tell who you are and where you're at. But you can do better. Some people do use it as an opportunity to pull their mark up quite significantly, possibly because they need to. Because you are going to be striving for a C+ or better, I hope, to pass the course. Okay, so that's all I'm going to say about a final exam for now. If you have any other questions, you can email me. I am going to talk about it a lot next week. What I'm going to do now is switch and talk about infections of the digestive system. So I see there's a couple questions. I'll get to you in a second. I just got to figure out what I'm doing with my PowerPoint here. Something is going on with my computer. I can't seem to, oh, there we go. Sometimes Zoom does some weird things for me here. Okay. So I'm thinking, okay, I got to share the screen. Okay, let's see what those questions are. So somebody's saying, is a C+ a 67? So yes, around there, yeah, around a 67. You know, if you're a 66.9, I'll round you up for sure. Besides that, I'm not sure. You know, usually when I look at the final exams, there's a bit of looking at the whole profile, you know, kind of thing. And so any specific questions, please contact me one-on-one. Okay, so about 15 minutes left. Might be enough time to talk about digestive diseases. And so the digestive system, of course, starts at the mouth, goes all the way through the stomach and the intestine. And these are the lists from the textbook. And you can see what I've done is I've bolded the organisms that we have featured in this course. But of course, there are many others. Some names have popped up a couple of times. Klebsiella, Haemophilus have popped up a couple of times, but they will not be on the final. Like I said, we just can't cover everything. So we're just trying to focus on the essentials. So if we start up at the mouth, something that I do not spend a lot of time on at all, again, it just gets complicated, is basically dental diseases. But there are a number of organisms in your mouth, and probably hundreds. And they can live on your teeth and on your gums and biofilms, which is why we brush our teeth. We're trying to remove those biofilms. So if you have a choice between a toothbrush and toothpaste, pick the toothbrush. Mechanically removing those biofilms is important for dental health. And this is why your dentist is probably asking you to floss more. So I do encourage you to floss. I can tell you it's made a difference for me. I never used to take it seriously, and it's certainly helped my teeth quite a bit. A number of these organisms, and I'll just introduce one here, a streptococcus, and this won't be on the exam, but a number of these organisms produce acids. And they produce acids when you feed them sugar. And so this is why, you know, sugar and tooth decay are kind of, you know, tightly correlated, because of course the sugar is broken down by these organisms. The Streptococcus, for example, lives in biofilms, produces acids, and the acids break down teeth enamel. So, you know, not saying don't eat your birthday cake, but sometimes, you know, rinsing your mouth out after a meal or brushing your teeth is probably good advice. So let's get deeper into the digestive system where we want to talk about. So we talked about the stomach. There's one main organism that's a concern sometimes in the stomach, and that's this guy. So I think there's a little animation here, I thought. Where is he? My animation disappeared. Yeah, so this is Helicobacter, and in Canada, about 50% of us have it. It doesn't mean you're getting sick. Most people are asymptomatic, but there are some strains that cause us issues, like ulcers and sometimes stomach cancers. So there's an ulcer right there. So an ulcer is kind of inflammation of the stomach. You know, it can cause a lot of discomfort and acid reflux and things like that. And like I said, some of these strains are associated with stomach cancer. Interestingly enough, there are some strains that actually seem to protect us from stomach cancer. So we don't necessarily want to get rid of it either, right? Because, and there's actually a lot that we don't understand about this. The association with ulcers, actually, we've only known about that for, I think, about 25 years. And so there's a lot of research still needs to be done. And it's hard to research, you know, these things, because to study the stomach, you almost have to get a biopsy in some cases. So again, animal models are helpful, but this organism doesn't necessarily colonize a lot of animals. So let's talk about the lower digestive system. And when we're talking about the lower digestive system, we're often talking about diarrhea. So diarrhea, kind of the definition is it's kind of, you know, the whole thing is more loose or liquidy than normal. A lot of physicians will define it as 3 loose or liquid bowel movements a day. So you have one, apparently that doesn't count. I don't know. I think there's some cultural context behind this. In some parts of the world, this is normal, having 3 loose or liquid bowel movements a day. In some places, it's not. But you know, usually most people have an idea what's not normal, and some types of diarrhea, of course, are certainly not normal. So we're talking about 2 types of diarrhea that you'll hear about. One is gastroenteritis, and this is kind of diarrhea that's just mostly liquid, no pus, right? Obviously feces in there. And there's dysentery, and this is where there might be blood included as well, right? And so the typical symptoms of both of these things are not just the diarrhea, but you might end up with you know, cramps in the gut, and vomiting is pretty common too, right? So, you know, digestive symptoms, diarrhea and vomiting. Probably no surprises there. So if you're looking at gastroenteritis, common causes. So we're looking at all the usual suspects again. We've got E. coli, we've got Clostridium difficile, we've got Salmonella. We'll talk about Salmonella shortly. Norovirus we're going to talk about, and we have Giardia. Dysentery, a little more serious when you're bleeding. So the important organisms are this E. coli here, 0157. That's the nasty one. That should be probably given another name, because some people argue it's not even E. coli. It has so many extra genes. And then we talked about this protist here, Entamoeba histolytica. So there's from the textbook. You can see they're giving a list of organisms, and you can see most of these are things that we're talking about. We're not talking about Campylobacter, although an important foodborne illness, or Shigella. So I just wanted to very briefly mention cholera, just very briefly. Partly because it kind of has a unique organism. It's got this this bent shape. So you can see these cells here have a bent shape. So that bent shape has a name. It's called Vibrio. So the name of cholera is Vibrio cholera. And this will give you apparently diarrhea like you have never had before. And the risk of you can die from it within 24 hours from just sheer dehydration. Apparently it's that bad. From contaminated water, like most of these organisms, they're spread through feces in contaminated water. Cholera, of course, is not transmitted in Canada, and I don't know if it has ever been transmitted in Canada historically. at least not in 100 years. But if you do traveling, particularly certain parts of Asia, India, it's very, very common for cholera to occur in the water there. So Clostridium we've also talked about as being an important organism in hospitals, and often it's associated with this term, antibiotic-induced diarrhea. And this is because it can grow in the gut and survive because it forms endospores, and those endospores are resistant to drugs. And so if you take drugs for some other reason, this thing may survive, have a chance to propagate and cause the antibiotic-induced diarrhea. Not everyone has it, but it's getting to be more common, and you can get this hospital acquired. It seems to be a common trend nowadays of people spending some time in a hospital for some other ailment. They take antibiotics, and somewhere in there they've acquired the Clostridium, and apparently this thing is super nasty. It has a very nasty smell to it. This one we also mentioned is something that is treatable by fecal transplants, and so we're probably going to hear a lot more about those in the future. So let's talk about traveler's diarrhea. It has many names to it. Sometimes we call it backpacker's diarrhea. So why are we calling it traveler's diarrhea? Because certain places in the world, it's common to get it. And we're talking about places that people might travel to, so for vacations or other reasons. I don't know how accurate this map is. I've seen a few maps, but you get the idea, right? There's a lot of places in the world where water sanitation is not at the high standards we have in Canada. Canada has amazing water standards for most of Canada. I think there's a lot of northern and remote communities that have issues, but most cities were in really good shape. And so traveler's diarrhea is from water that's contaminated by feces. And so that's not usually the case in Canada anyway, but in other parts of the world, it's a little bit more common. Now you can get immunity to this, but it takes a while. So there's a lot of people that, maybe you're from Mexico, or, I'm not just trying to pick on Mexico, but that's the most common place Canadians get traveler's diarrhea from. Or you may be from some part of Africa, and the reality is you probably had a lot of diarrhea when you were young, and eventually you do get immunity to it. But if you live in Canada for a while and you go back, you may not be immune anymore. It's not a long-lived immunity, unfortunately. So you can see this slide here is saying, okay, what are the common causes? Often it's E. coli, certain types of pathogenic E. coli. Sometimes it's other organisms. There's a whole bunch of bacteria that can cause gastroenteritis kind of symptoms, but the big one is E. coli, sometimes Campylobacter and Salmonella. Sometimes there's a protist, so Giardia and Cryptosporidium are pretty common. So if you have that diarrhea and it lasts you 2 weeks or more, you probably have a protist. If it lasts you, a couple of days, it's probably E. coli. Somebody's asking about Dukoral. That's actually an oral vaccine that you can get. Apparently it is okay, but not super effective. I think the immunity from Dukoral apparently is only estimated to last about a year, and I think it only protects against certain strains. I think in the last couple of years there's been a number of studies to sort of kind of suggest it doesn't give the best protection, but I think you can still get it. I remember learning about it a number of years ago, but I can't tell you a ton about it. But it is an oral vaccine you can take. It's basically like a little fizzy drink, and I'm not even sure what's in it in terms of the vaccine. But good question. So if you are anticipating travel to one of those places and drinking the water, then worth it to look into for sure, 100%. So I don't know why that is so big. I meant it to be small. I had mentioned that some probiotics are claiming that they can protect you or help you alleviate the symptoms of traveler's diarrhea. Oh, there's the little one. I don't know why it was big as well. Sorry about that. So E. coli, of course, has many strains, and I keep trying to tell you not all strains are bad, but these ones over here are the ones that are usually considered to be pathogenic. And these ones, E-Tech and E-Pec and all that. And just to kind of re-emphasize what we talked about before, why are they pathogenic? Because they have virulence factors. that other E. coli do not have. And what virulence factors are we talking about? Things like toxins, enterotoxins that cause diarrhea. Sometimes we're talking about pili that allow them to attach to cells, and sometimes flagella that help them to invade the body really well. So you don't need to know this slide. Like I said, kind of the takeaway message is that these things are pathogenic because they have extra genes and extra things like toxins that make them, that allow them to make you ill. So foodborne disease, I think what I'm going to do, I want to talk a little bit about salmonella, and then maybe I think we'll be out of time. I guess we'll probably have to save norovirus for next day, unless I have norovirus first. I can't remember which order I put these notes in. But I think I showed you this slide before and showed you, in terms of foodborne illness in Canada, this is the list. These are the top 5. And actually, it's a different list in the States. I think norovirus is still #1, but this is apparently the top 5 according to this information I got from public health anyway. So most of this foodborne illness is food contaminated with feces, animal or human feces. And so it happens, right? So sometimes we talk about this as being food poisoning, and I kind of don't like that word because it's not very specific. And what does it mean? So we can kind of classify foodborne infections into 2 categories, right? Food intoxication, and that's where we actually have an organism that is producing a toxin, and it could mean you could die. This is usually we're talking about botulism. There are some strains of Staphylococcus that produce toxins as well that can cause severe illness. So nausea and vomiting and severe illness. These are a lot more rare. Usually when people are talking about foodborne disease, they're talking about food infection, and you can see the common things. There's that Campylobacter again. Maybe a future year I'll put it more in the notes, but we're talking about salmonella and E. coli, and sometimes listeria. It seems to pop up in there quite frequently. So I think I'm just looking at the time, and I think what I'm going to do is stop there and come back to this next day, because I don't want to rush through salmonella. I don't have a lot to say about salmonella, but I just feel like I'm just going to rush everything. And I think, probably some brains are full already, so maybe it's just a good time to stop for the day. So Thursday is today, and like I said, next week what I'm going to do is on Tuesday, I'm going to wrap up this topic 14 and talk a little bit about the final exam, and then next Thursday will be all about the final exam, and we'll go from there anyway. If you have any specific questions, let me know. I know some people are probably wondering, what about those assignments? And I said I'd hope to have them done for today, and I may still get them done. I just keep getting all these things thrown at me, yesterday my boss wanted me to do something, and that put me behind, but it is my next thing to do, meaning that I'm going to go to my office now and probably answer a few emails and probably get started on the assignments after lunch. And so if you're lucky, I'll have it done today. If not, I think tomorrow I can probably guarantee it. Anyway, have a good weekend, and take care, and we'll see you next week.